It's pretty, I think, hopefully, well delineated, and I'll point out some of the things and specifics you need to know. So, with that said, the hardest part of block 3 is dragging you guys across the emotional finish line. Okay? So that is really where this block becomes big and hard, is trying to get you guys emotionally over the finish line. We'll do it. We got it. So we start with peds neurology. And I have to say that you guys hear me all the time. I'm like, I love this one so much. I hate peds neurology. No. I cannot stand this topic because there is so much that we don't know about it. There is so much that we don't know how to manage. And there's a lot of times where we're very limited in what we can do. So it's not one of my favorite topics. However, it affects a lot of families and people. So it's important that we talk about it. So we'll have some videos too in the middle right after break this. Okay? So seizures. If you're thinking way back to neurology, which I think you had with Colonel Rogers, right? What is a seizure? Everything fires at once. So what it is uncontrolled electrical activity. That's basically all that a seizure is. You have electrical activity going between your neurons all the time. It's usually in a very controlled pattern. Seizures are when that pattern is uncontrolled. So uncontrolled electrical activity between the various neurons is all we're talking about. So in general, your epidemiology of this is pretty high. 1 out of every 10 to 1 out of every 20 kids is going to experience some sort of seizure by the time they are done with puberty. It's a pretty high amount of kids. But when most people are worried about seizures, what they're worried about is recurrent seizures and epilepsy. So a couple of things with epilepsy. To meet that diagnostic definition, it needs to be recurrent. It has to happen over and over and over. And it has to be unprovoked. So unprovoked meaning it's not from a TBI that you had something happen and this is secondary to that. Certainly that can be one of the causes, but typically epilepsy in childhood is defined where it's recurrent and unprovoked seizures. What we're going to mainly talk about are the first two categories when we're talking about focal seizures versus generalized seizures. There's a whole big subtopic where you have this unknown onset and then unclassified seizures that's well beyond the scope of that. That's a lot of like, don't know why it happens, don't know what's going on, and that's really outside of the scope of what this class is. So we're not even going to touch those two. We're going to mostly focus on focal and generalized. So we talk about those two and we look at them further subclassified. We talk about generalized seizures. That's meaning general of the whole brain. So your entire parenchyma is involved in this. So it used to be called grand mal seizures. We now call this tonic-clonic seizures. So you're thinking, what part is tonic versus what part is clonic? What part of that is the rhythmic jerking motion? The tonic or the clonic? The clonic part. Yep. What is the tonic part?
Flex.
Rigidity, correct. Mostly rigidity. So that is what typically is going to happen first. That's why we call it tonic-clonic. The rigidity is going to happen first, followed by that rhythmic movement coming diffusely from the brain. What I need you on 3 to do is everyone give me your best absence seizure. Ready? 1, 2, 3. Perfect. Right? So you've got your absence seizures. We had previously called those petit mal. And then under generalized seizures also, we have the febrile seizure. So that is where that one is going to go because the entire child's body is fevering, and the entire brain is febrile. So that is why that one falls under the generalized seizure. For your focal seizures, just part of the brain, part of the parenchyma, so not the whole thing. And you subclassify those, is their consciousness preserved or not? So if they're still aware and conscious, it's just part of that brain, simple. If they have altered consciousness and it is just part of that brain, it is now a complex focal seizure. Really frustrating because 3/4 of these, we have no idea what's causing this. Don't know. So there's a whole lot more in the genetic sphere and you're starting to see a lot more of these genetic classifications of seizure disorders. But for the most part, we don't have a good understanding of what is going on with seizures. Certainly you can see seizures after trauma, so we see that a lot with certain contact sports that we'll talk about later today, MVAs, any kind of accidents that are going on. You see this with your metabolic derangements. So you will have to know these 4 electrolytes over and over and over for this block. So the things that are going to cause these derangements, will cause them in all humans, but particularly for kids. So a low or high glucose can make you have a seizure. Low or high sodium can make you have a seizure. And then low calcium, low magnesium. And if you're trying to say, I need to order this, how are you going to get all of these electrolytes? CMP. What doesn't come on the CMP out of those? Magnesium. Correct. So you're going to have to order that one separately. What else could you order in an ER type setting? To get electrolytes. Really quickly. I don't know if you remember. A blood gas. So you're going to order, you could order a blood gas. Other things that we've already talked about, infectious causes. We talked about that last block. So encephalitis or meningitis. If you have a space-occupying lesion, so it doesn't always necessarily have to be a tumor, you could also have a hemorrhage. That can be another reason for that. And then we'll stop for a while on the febrile seizure, most common etiologies. So that's really where your history is looking for those type of etiologies of what is going on. When you're looking for these generalized seizures, remember this is the whole brain, it's going to start diffusely most of the time. There are some classifications where it can start focal and then almost kind of spread to the rest of the brain. See that one? Neuritis, or he classified it as your tonic-clonic. So when you think of that tonic movement, it is usually the rigidity can be followed by eye movements. This is also then because everything is rigid, the child can sometimes stop breathing. So that you see that cessation of the diaphragm movement as well, hence some of the apnea. And then you guys nailed it, the clonic part is the rhythmic jerking. So if you have children with epilepsy, there will sometimes be a specific pattern that they will have, and they will seize in a certain type of way recurrently, and that can be helpful. The parents will often come in and say, this is one of their typical seizures, or this is not, or this is lasting longer than their typical, something to that effect. Incontinence typically shows that it is more likely than not that it is a seizure. So this is one of those things that if you see somebody seizing, it generally freaks out most of the general population. So a lot of teenagers have figured that out. And this is an area of acting for some teenagers. They will pretend to have seizures. You'll probably see stuff like this. People will pretend to have seizures if they're getting arrested. People will pretend to have seizures for various different reasons. Teenagers are not immune to that. I had an attending, we had a couple of frequent flyers in residency of these kids that would pretend to have seizures. They would come in and one of the attendings would be trying to do a history and the kid is pretending to seize in the bed and the attending would just hit the bed real quick and the kid would stop, look up at him, and then proceed to continue to seize again. So that is one of the things that you will see. I never had a teenager go so far as to pee their pants to convince us that it was a seizure. So if you do have incontinence, that can be one of the things that will tell you that's more than likely a true seizure. The other thing will be a post-ictal phase. So if you think about shutting your computer down, if you think about those awesome new Oz computers you all have, if it's trying to restart, once it's been shut down, it's trying to reboot. That is functionally what the brain is doing during a post-ictal phase. It's kind of rebooting. So they're in a little bit of a gradual return to consciousness, kind of not with it, but not with it. So it's really just this kind of in-between rebooting stage. Usually the length of the seizure will correlate with the length of the post-ictal seizure. So if it was a very short seizure, oftentimes a shorter post-ictal, a longer seizure, a longer post-ictal. Your labs, there's no shotgun labs for that. Things that I definitely consider are all those electrolytes. I also consider toxicology for children, especially if they're younger toddlers. Maybe they could have gotten into something. If This is, if you are worried about a mass or a bleed, so a space-occupying lesion, then I do think potentially of a CT for a generalized seizure, but not often. So this is, again, not shotgun. So this is not the run-of-the-mill, every time you have a seizure you need a head CT by any means. EEGs. So, do you guys remember your EEG class that you took? Right, because you didn't have an EEG class, okay? So if you think about how, some of you were like, oh my God, did I take an EEG class?
I've heard those letters before in that order.
But if you think about it, right, well, for these neurologists, they did medical school, they did internal medicine or pediatrics for 3 years, then they did a 3-year neurology fellowship, then they did another 1-year sub-fellowship in EEG. So that is how complex EEGs are, and that is how few people do them and read them. So when you're thinking, oh, I'm just going to get an EEG in the ER, that's probably not the case. So it's probably going to be lower yield to pick on a test for me or for parents, okay? Because EEGs are not particularly fast, they're not particularly helpful in all cases, and if they're not seizing, they can be normal, and so that can be less helpful. That's different than your ECG class that you did take. I hope that you remember that you took that one. Okay. Your treatment, when you are thinking, who am I referring to? You're referring to pediatric neurology, and your common meds are going to be oral oxcarbazepine and levetiracetam. From here on out, I will call that one Keppra. You will probably never hear levetiracetam called levetiracetam again. It will be Keppra, K-E-P-P-R-A, from here on out. When you start seeing this, you're going to see this in slide after slide. You're going to say, consider head CT, consider labs, consider EEG, refer to neurology, oxcarbazepine, and Keppra. Okay? That means that it's difficult to test that because they're all the same. Okay? So if you can identify the seizure, that's more of what you're going to need than to be able to know what the treatment is going to be. Focal. So we said focal meant just part of the brain. And then this one, when we were talking about simple focal, your preserved awareness is still part of it. So a lot of these kids still know what is going on. They will often then potentially have those motor symptoms just in some of the areas. And a lot of kids with these will have auras. So anybody been around a kid with simple focal seizures that are getting auras, or even adults? Because they're common auras. What type of aura do people typically say? Smells. What do they smell often?
Burnt toast?
Burnt, yes. The burnt smell. Burnt toast, burnt rubber, burnt oil. There's a lot of burnt things. So if you see test stems that say they were smelling burnt toast earlier that day, that should be a key. Hey, they're talking about a seizure or a potential aura that they're having. Those auras can last minutes or hours. And when they start having these focal seizures, they are not under voluntary control. So if you're trying to pick between, is this a tic? And this kid is having this tic-like movement. Tics you can voluntarily control. Seizures you cannot. So this workup, consider the CT scan. What I will say for focal seizures that you don't know what's going on, just for focal, I have a more likelihood to get imaging for that because that means just one part is off, and that's weird. That's more unique, that's different. So I have a higher threshold to consider some sort of head imaging for your focal seizures. When you're doing that imaging, what are you suspicious for? If you're not thinking, okay, it could be seizures, what are you ruling out again? Masses or bleeds, okay? Do you know, does anyone happen to know where children will often have masses or bleeds? What part of the brain? Is it frontal, temporal? Yes, in the cerebellum. So it's really in the posterior fossa. The thing about CT scans, terrible for the posterior fossa in children. Absolutely horrendous. What study do we want? An MRI, yeah. So I would much rather have and be reassured by an MRI to say, oh, I don't have a bleed or a space-occupying lesion, than a CT scan. So even that, I'm like, CT scans, unless I think it's an acute bleed, an acute accident that's been happening, I would much prefer an MRI. So again, your labs and imaging, you're like, CT scan if you think, EEG potentially, neurology for oral oxcarbazepine and Keppra. Same thing over and over. What about if you have impaired consciousness? So now we had these focal seizures, but now the child doesn't remember them. So potentially they are still preceded by an aura. And what your textbook will say is it's less likely if they are under 7. I sometimes have a problem with that because under 7, if you're having recurrent seizures, that is your normal. And so is it really that they're not having an aura or that they're not recognizing that they're having an aura? Potentially more research in that to come. The things that you will see with consciousness being altered is that they will sometimes be looking around and seems like they're with you, but they're not. So that consciousness, they don't remember it, they do not remember an event. So not only is incontinence one of the things you see for true seizures, another thing that you see for true seizures is the post-ictal phase, and then they don't remember the event. So if you get a teenager that's coming into the ER and they're telling you that they remember having a seizure and they snapped right back to it, they probably didn't have a true seizure, just by the history. The autonomic system gets very dysregulated in this as well. So you have an increase in different autonomic functions with this. So sometimes that can mean that you have these automatic movements of the face and the hands or extremities that are outside of their control. Sometimes you then see the autonomic nervous system with pupils dilating. Is that going to be sympathetic or parasympathetic? Pupil dilation.
Parasympathetic?
And then when you have salivation, is that para or sympathetic? Para, yep. And then flushing. Yep, so you can see this, that sometimes you get some of each, so all this stuff going on. Let's look at our labs and our imaging. We're considering a head CT or an MRI if it's available. Consider your EEG. Refer to neuro, oral oxcarbazepine, and Keppra. Right? You can see how this is going to be harder to test for treatment-wise. Everyone do your absent seizure again, real quick. 3, 2, 1. You're amazing. You guys just do an amazing absent seizure. It is incredible, uncanny. What I need you guys to take away from that is, what if this is happening in this primary age group when it presents? Age 4 to 6. What are they starting around 5? School. So if you're having hundreds of absent seizures a day, where you're just staring off into space, what does that look like then?
Bad grades.
Looks like you don't care, looks like you can't read, looks like ADHD. So a lot of kids will get started on a lot of different things when it actually is the emergence of absent seizures. No aura with this, and no post-ictal, so they'll immediately return. Things that differentiate this. Oh, this is a buzzword for your pants. There is no world, and I will just be very frank with you, there is 0 worlds in which you would show me an EEG and I could say, oh yes, that's a 3 Hz spike and wave pattern. 0 worlds. Which you better believe, if I saw a 3 Hz spike and wave pattern in the question stem, I'd be like, that is an absent seizure. Okay? That is a buzzword and I need you to know. 3 Hz spike and wave. That goes with absent seizure, and that is a difference in treatment. It is a different type of seizure. It is a different treatment. Ethosuximide is your treatment of choice then. Okay? Those are those 2 different ones for that. Febrile seizures. I'm going to ask you a question on them, maybe 2. Don't know yet. We'll see how much feeling the fever by the end of this. Okay? So, febrile seizures. Star that one and highlight this. You're going to need to know this. Your key time frame, your textbook says 6 months to 5 years. I classically learned 6 to 6. 6 months through that 6th birthday, 6 to 6. A lot of kids will have this. So if you're thinking, yeah, every out of 100, I'm going to see 5 kids that are going to have this, and then once they have one, it's truly a coin flip if they're going to have another one. So febrile seizure is very, very common. What 2 things do you need to have in order to have a febrile seizure? Fever and a seizure, right? I promise you, you're going to be seeing someday where someone will say, they had a temperature of 99 and they had a seizure. It's a febrile seizure. No, ma'am, it's not. You need a fever and you need a seizure. Those 2 things to have a febrile seizure. It can be before, during, or after the seizure. And it doesn't have any correlation with the elevation of the fever. That's typically parents' fears. When do I need to go to the ER? When it's 103, 104, 105? There is no number. It is the speed at which their body's regulation changes. So, you've heard the classic, if you put a frog in water and you slowly turn up the temperature, the frog will stay in the water, versus if you throw the frog into the boiling water and it will pop out. Kind of what's happening. If you have a child where the temperature slowly rises, their body handles that well. If you go very quickly from a normal temperature up to a febrile temperature, in a matter of minutes, that is when you get the frog jumping out of the hot water analogy. And the brain will kind of have that uncontrolled electrical activity and they will seize from that fever. You also have to have no evidence that it is something else. So if the child comes in with a fever and a seizure, but the question stem or in real life, the child is unvaccinated and has petechiae, what are you thinking of? Meningitis. What kind of meningitis? Neisseria, right? So at that point, it's no longer a febrile seizure, so it's a diagnosis of exclusion. Now you're treating Neisseria meningitis. Classifications. Star, underline, highlight this one. You're going to need to know this one for the febrile seizures. How do you determine if it's simple febrile and you, the PA, can handle it, or if it's complex febrile and you need somebody else? So for the simple febrile seizure, you need 3 things. Number 1, it needs to be a generalized seizure. So their whole body, the whole brain is involved. Remember, because they are febrile, the whole brain. It is a generalized seizure. It needs to be less than 15 minutes from start to finish. And it needs to only happen 1 time in a 24-hour period. The kind of 4th caveat with that is they need to be normal neurologic children at baseline. If you already aren't at a neurologic normal baseline, then you already are in complex. If you meet those 3 diagnostic criteria, you have an amazing prognosis. It doesn't mean you are any more risk of epilepsy, doesn't change any kind of outcomes whatsoever. So I call it one of those normal abnormals. Is it normal that a child has a seizure? No. Is it so common and it has benign outcomes that it's one of the normal abnormals? Yeah. So very much freaks families and parents out, freaks providers out, freaks the ER out sometimes. If you meet all of those diagnostic criteria, you are fine. If any one of them is not that, then you are in complex. So if you have a child with a seizure disorder, if you have a child with cerebral palsy or another kind of underlying neurologic disorder, they are already complex. So there's that caveat. But then if you have focal seizures or a focal exam, something is off but the rest of their body's fine, it's focal. More than 15 minutes or it reoccurs in 24 hours. Any one of those, it is complex. And then it becomes something that you will engage neurology for. So please know this one. Star, highlight, underline this one. Things to think about. Have I ruled out that it's meningitis? With your brain. When you're thinking PE, you're ruling this out with your brain and with your exam. Okay? You're not just doing LPs on everybody. But I'm thinking to myself, is this meningitis? Is this encephalitis? Do I need to do other things? If your brain has thought that to yourself and you're thinking, oh, I really do need to do some more workup here, a couple of things to think about. I am going to look for, are there focal signs or is there papilledema? What am I looking for? Increased ICP. If I have increased ICP, what's going to happen if I put a needle in the kid's back? It's going to herniate. You're going to herniate right through there because of that pressure differentiation. So first off, get a CT scan to make sure you don't have that space occupied lesion. If you're somewhere that has a fast MRI, get a fast MRI. The textbook has CT. Get imaging before you proceed. You could do the EEG. It's not going to be performed urgently. Not at all. So if you call, I learned the hard way and I consulted neurology in the middle of the night for a stat EEG. And they hung up on me, right? So they're not going to come in to do a stat EEG for this at all. So not urgent, not something you need to do, but consider with neurology. What is your management then? Well, if they meet those 3 diagnostic criteria, what were the criteria? Less than 15 minutes, 1 in 24 hours, and what type of seizure? Generalized seizure, yep. So if they have that, usually has no treatment needed. A lot of reassurance and education for the families. They return to baseline. Things to think about. How long was that seizure? Even if it was under 15 minutes, that's still a long time to seize. And I'll tell you why that is still the diagnostic criteria in a little bit. But things to think about is rectal diazepam if that seizure is longer than 5 minutes. You want to stop some of the seizures. Sometimes parents are really uncomfortable with that medication as well. It's a little bit fallen out of favor. You'll probably start to see more intranasal Versed used over time, but still right now the recommendation is consideration of rectal diazepam. Not at risk of needing an anticonvulsant, so we're not starting any other medication. And the biggest takeaway from this that I want you to star, highlight, and underline is do not recommend that they take round-the-clock antipyretics. It has not shown to do anything other than overdose kids on Tylenol and Motrin. It doesn't reduce the number of febrile seizures. It doesn't decrease the likelihood they're going to have them. Most of the time, it happens with a first fever of an illness, and that is when they don't even know that they're having fevers, and so we miss that first one. So the only way to do that would be if you kept them on it 24/7, 365, and even then, it didn't change any kind of outcomes. So regular use of Tylenol and Motrin, nothing where they're taking it all the time to prevent that. Some of the education that you're going to give these families. So we want to make sure that the child is in a safe spot. So moving them to the floor. And this is just good seizure management for everybody because you see everybody freak out. What happens when people start seizing? What does everyone do? They back away and they're like, oh my God, I have somewhere to be. Right? They just kind of walk away. This is what you see. What I need you guys as providers to do, get the person to the ground so that they, or especially the child to the ground, somewhere where they're not hitting their head. I don't know what 6 months to 5-year-olds are wearing ties, but if they are wearing a tie or any kind of tight clothing, or chokers are making a comeback for the kids, so making sure they don't have anything tight around their airway. Turning them on their side, what are you trying to prevent by turning them on their side? Aspiration risk, so it's going to decrease that. Time it, right? So if you, I will sometimes sit there and be like, how long was the seizure? What is every parent's answer? How long was the seizure? Forever. And you're like, yes, seizure time is forever time. But sometimes we'll sit there and be like, let's mark off how long you think it was. Most of the time, I would say it's between a minute or 2 minutes. But getting them to say, time it, if you start seeing that, so that you have a general idea how long it's been. Don't put anything in the mouth, don't hold them down. Just general seizure guidelines for education for these families. Things to think about. This I have a problem with. I have big problems with your textbook, and I will tell you why. Okay? So things to consider. We already talked about this in block 1 of when you would restrict someone from sports. So when would you restrict someone from contact sports? How long do they need to be seizure-free for? 6 months, correct. The other thing you need to be seizure-free for 6 months if you have an older child would be driving. The scariest part of this is that it's the same for adults. It's self-reported. So you are relying, we are all relying on the roads for everyone with seizures to self-report they have not had a seizure in 6 months and are well controlled. That should terrify us a little bit, but it is self-reported. For children, I guess for anyone too, we would say prefer to not swim alone. You don't want them to have a seizure in the water and then drown. And then specific sports. So this is back when we were talking about, hey, what can these kids do? One of those risk stratifications is to put them in different groups. So the least risky is going to be group 1. They are going to be, this is safe for patients, this is safe for the people around them. So things on the ground, golf, tennis, dance, bowling, things like that, often very safe for kids with seizure disorders to do. It's group 2 that I have some issues with. So group 2 says it's moderate risk to the patient, but not to the bystander. But that, archery? Or the biathlon? Not for bystanders? Like, okay, but that is still a group 2. I would put that in group 3, but that is me. Group 3 is risk for bystanders and for patients. So a lot of things where there is something else involved, a horse or some sort of motorized sport that is involved. So my beef is really with the biathlon and archery. I feel like that is a risk for bystanders, but you will let it be what it is. Status is a little different. I have a problem with status too, so I'm so sorry. I have so many problems today that you're hearing about. So previously, when I was in residency, when I was coming up, and it was a relatively recent change in the last couple of years, so your textbook still has this, is that status for a child was 30 minutes. That is like forever long, right? Status in a child was 30 minutes. Do you know how long 30 minutes of seizing is and what is happening to your brain? What electrolyte is being used like crazy amounts during a seizure? Your glucose. So if you're watching somebody just seize for 30 minutes, that's wild, right? So the Society of Neurology has moved it down. So the definition of status for a child is the same as adults now, over 5 minutes. Problem is your textbook still says 30, so I'm not going to ask that particular question because I hate it, and it's a bad question, but it is 5 minutes. What you will see then is you have some problems now with those simple febrile seizures being under 15, because you're like, wait, but if it was 12, it's simple, but it's status. Yes, that is the consensus right now, is that if it's a febrile seizure, we're still using 15 minutes, yet for all other seizures, we're using 5 for status. Welcome to pediatrics. We're still trying to figure it out. The mortality of this can be relatively high. They do go into status. So what are the causes? This could be new onset epilepsy. This could be the first time that they're ever having a seizure. This could be that they took something. This is a young child or an older child that was doing this intentionally. But more likely what we see is it's often a withdrawal. So the kids are dosed appropriately. Then they do that thing they do and they grow, but their seizure medication, it doesn't correlate with that. And so they are underdosed for their seizure. So that's what you will often see for children with that. Your electrolyte disturbances, what are those 4 electrolytes? Glucose, sodium, calcium, magnesium. Yep, that you'll see. Sometimes hypoxia can do this. Any kind of head trauma. Infants can have strokes. In the HEMONC, we'll talk about a few of those reasons for children to have strokes, and then infection. Did we see seizures more commonly with meningitis or encephalitis? Block 2. Encephalitis, correct. When you're treating these kids, ABCs are always going to be your first thing. You need this airway for these kids. I always get a cardiac monitor, so this one you will do, because you took an ECG class. Oxygen if they need it, an IV, and your meds. What is your classification of meds that we're using there?
Benzos.
Benzos, yep. So pick a benzo. Any benzo will work. What we're doing, you guys already nailed it with those electrolytes. A lot of these drugs, you can get the drug level. So it's not a quick lab. but it's really helpful if they're in the ICU. So you'll get a Keppra level. That's one thing you can order. So if you're in the ER and you have a kid in status, ordering the drug level of whatever they're on, and then tox studies. This would be one that they go to the PICU. So this isn't even one that you're going to be managing on the floor. Status is going to go to peds and to the PICU. Okay. That was all on seizures. When we come back from break, we'll have, I just want to show you guys a couple of different videos of what some seizures can look like. It can be a little bit subtle in kids and in babies. So just an idea of what that is. It can add headaches in these kids. So one thing that I want you guys to notice is we're missing a type of primary headaches in these kids. Which one are we missing? Cluster headaches. In all my years, never seen a child with a cluster headache. In all of pediatric neurology and in all of those folks, really don't see cluster headache in children. Should you pick that on your exam?
No.
Don't pick that. You see a child on your pants and you're thinking to yourself, ooh, I want to pick cluster headache. Don't move that finger. Do not pick that, pick something else. Because children are going to get tension headaches. Children are going to get migraine headaches. Functionally, you do not see cluster headaches in children. If you're thinking that's the diagnosis that I'm going to make in clinic, you should probably refer. That's the takeaway of that. You're doing those primary and secondary. We see a secondary ton with humans because they get sick every kind of time they get a cold or a sinusitis. And then we talk ad nauseum about different brain, meningitis, otitis media, all of those good things from 1 2. So what are your red flags for kids when we see this? So caveat with this one is that if you see worst headache of your life on a board test, that's your buzzword, right? Worst headache of your life. And then it's an adult patient, what do you think? Subarachnoid, right? You see worst headache of my life in kids, I start to think more of rare things like an AVM, arteriovenous malformation, other stuff. But I need you to take it with a grain of salt. If you have somebody that's writhing around in pain, or a parent tells you this is the worst headache of their life, I take that a whole lot more serious than the 15-year-old that's playing on their phone and like, this is the worst headache of my life. Use your provider brain. Right? Morning headaches. Most kids, if you have kids in here, you've been around a kid, kids feel like $1 billion in the morning. They like bounce out of bed, the sun is shining, the birds are chirping, they're like ready to run around and be crazy every day. Like I can't even imagine. But if kids wake up with morning headaches, red flag. That's not normal. If the pain wakes the child up, that's not normal. So this is not that they wake up with a headache, that's also a red flag, but does the pain wake them up? If the pain wakes them up, what are you thinking? Cancer. There's some sort of mass in there. Something's not normal. Chronic progressive headaches, that's a red flag, not normal. Abnormal focal findings, what are you thinking? Mass. Where's the cancer? Correct. Changes with body position, what are you thinking? Mass. Correct. Recurrent vomiting in the morning, what are you thinking? Mass. Yes. And no family history. Most primary headache types, tension and migraine headaches, have like 90% family connection. So if this is out of nowhere, that is one of the red flags that I do a more thorough history of this on. Know these flags. Your tension is going to look like other humans. So the biggest differentiation on this for real life and on tests is that it's been a long time and it doesn't stop them. It's not disruptive. They're not missing school. They're not missing soccer practice. It's not keeping them from hanging out with their friends. Oftentimes you'll pick this up on a review of systems where you're going down into any headaches and then they're like, you know, yeah, I have had headaches. And you're like, how long have you had headaches for? And you're like 4 years. You're like, great. So, okay, here we go, right? That's more likely a tension headache for the adults and for the kids. You'll often have trouble describing it for you, so if you're talking about a squeezing, that tension, I'll sometimes take the child and hold their hand or squeeze on their head to say, does it feel like that? So kind of a global squeezing sensation. It doesn't have those classic nausea, vomiting, photophobia. With children, particularly prepubertal ones, I'm looking for what's going on in the family. Deployments of grandma moved in, a death, divorce, bullying, something else is going on most of the time for tension headaches for those kids. Compare that to migraines. Migraines are going to have the same thing that you see in the adult world. So the same exact type symptoms, nausea, vomiting, photophobia, very, very similar. Look for that family history. So this is one, again, 90% have a first degree relative with this. So if this is like out of nowhere, that should be, again, one of those red flags that makes me think, They also come in a lot quicker. So these are the ones that are disrupting their life. I'm missing fourth period 3 times a week because it's in the afternoons. I can't go to soccer multiple days a week. I don't even want to go hang out with my friends because my head hurts so bad. So what's the function that is impaired for these children? Your first line medication management then is going to be your Tylenol and your Motrin, acetaminophen and your ibuprofen. What was your dose of acetaminophen? 10 to 15 mg per kg. Ibuprofen? 5 to 10, correct. What's going to be your first thing? There can be a rebound NSAID headache, so my first go-to is acetaminophen for any kind of headache management, along with my antiemetics and my hydration. So ondansetron is my go-to. So my very first line says, let's make sure you're on appropriate dosing acetaminophen, appropriate dosing of ondansetron or Zofran, and Gatorade. Make sure their glucose is okay and they're hydrated. That's my very first step of migraine cocktail. My second line is the triptans. Okay? What are the triptans doing? What are they doing?
It's like vasoconstriction?
Correct, vasoconstriction. So we're kind of trying to constrict those vessels so that there's not as much pounding. My favorite is rizatriptan because it comes in a liquid form for kids and then as well as a form for older kids who can take it, so it's just easy dosing for that. Things that we don't give those for, if it's a basilar migraine or they have focal migraines. So focal symptoms, again, should make you think, I need to scan this. This isn't normal. Anything focal, scan it. As a reminder, if they have migraine with aura, that is still a contraindication to estrogen-containing combined oral contraceptives. Your prophylaxis. So this is interesting. I think it's interesting. So most of the time we say refer to neurology, right? You're out in a small base. What do you think my wait time for peds neurology was out in the community?
3 months.
It was typically 8 to 9 months. So I'm hanging on to these kids with migraines that they're having disruptive migraines more than 1 a week. So they're missing school more than once a week, practice once a week. Parents are doing work once a week to pick these kids up. So your prophylactic headache medication, what does it tell you when there are, 5 classes of medications up there? What does it tell you when you have 5 classes of medications for one thing? We don't know, and none of them work super well. So all of these work about 40% of the time. Again, a coin flip. So flip the coin, maybe it'll work. The recommendation to people is that they, in real life, in practice, find 1 or 2 that you're comfortable with trying while you're waiting to get these kids somewhere. My personal favorite was topiramate or Topamax and cyproheptadine or Periactin. Cyproheptadine, nerd out history moment for a minute. It was a antihistamine that did a really terrible job as an antihistamine, but the side effects were it made kids really hungry, so we use it for appetite stimulant, and it helps with migraines. So terrible antihistamine, but we harness the side effects. So recommendation to become comfortable, even with the adult world, of 1 or 2 of these prophylactic medications that'll work about half of the time. and to try these before you send to neurology. You have a much better chance of saying, I optimized my lifestyle, I optimized first line, I optimized my sumatriptan, I optimized a prophylactic medication, it still is not working, neurology over to you. That is a good place to take a break, come back at the top of the hour in pediatrics. So common things being common in peds, really we're thinking these kiddos, they have a viral infection, they had that sinusitis and it's more of that facial pain, global headache sensation. Medication overuse. What medications give rebound headaches? We've talked about one. NSAIDs, yep. What other things might teenagers be using a lot of that has withdrawal headaches? Caffeine. How many energy drinks are you drinking? How many times are you going to Starbucks? Right? Things like that can be something to think about. And then trauma, and then your ICP. We'll talk about some of the other causes of ICP in a bit. Your secondary red flags. We said primary red flags. The nice thing about your secondary red flags is they're the exact same. So if you're looking at lying down makes it worse. So what did your mom always tell you to do when you had a headache? Go lay down. And that fixes the majority of children's headaches, right? If you go lay down and it's worse, red flag. Awakes from sleep gets better when you stand up, concerning that there's going to be increased pressure there. Exaggerated with increased intra-abdominal or intrathoracic pressure, going to be a red flag, and then obviously any papilledema or focal signs that would show you increased ICP. So functionally your red flag lists are the exact same for primary and secondary. If you have none of those red flags, none of them, don't image this kid. It's unlikely that it's anything other than these types of headaches. Don't image them. So when do you image? It's that same pattern. I image if I have increased ICP, focal signs on exam, or something really abnormal. So those red flags, or there's something on exam. I can't feel my face or parts of my leg. It's stroke-like symptoms in a child. My consciousness is out of it and it's staying that way. It's progressing and significantly getting worse. Right? All of those things should be kind of considered red flags as well. That's when I need you to image. Otherwise, we're not imaging. Again, you're getting a quick head CT for brains and bleeding. Make sure before then you do a lumbar puncture that you have that. The big thing when you are getting your lumbar puncture, it's not just about collecting that sample. I need to see what the opening pressure is. So as soon as you put the needle in, it will give you back how many millimeters of mercury, how much pressure is in that spinal canal, and that pressure can be helpful for making diagnoses later that you need an opening pressure for. So opening pressure is one of those things to get when you're doing a headache evaluation LP. Different than if you're going to be getting meningitis workup. And then again, if you can, get that brain MRI, better posterior fossa that you have. So your treatment, we already talked about that. Your first step was lifestyle modifications. Remember, if you can choose avoid the trigger or lifestyle modifications on your pants, pick that one. So that might mean you'll see teenagers that you're like, you'll be like, I get headaches in the middle of the morning. You're like, did you eat breakfast? They're like, no. You're like, when did you eat dinner? They're like 5 o'clock. You're like, so you haven't eaten in 17 hours and you have a headache? Just Sherlock Holmes right here, right? So a lot of times that regular eating, regular sleeping, regular meals, avoiding caffeine, avoiding triggers can be very, very helpful. We already said your management, your first line, making sure rebounds, naproxen can be used. That opening pressure then, what I need you to remember is idiopathic intracranial hypertension. I still have trouble not calling it its old name. It was pseudotumor cerebri. If you were a parent and you heard your child has pseudotumor cerebri, what part of that do you remember? Yeah, the tumor part. And then you have lost them. And they're not listening to anything else because all they heard was my child has a tumor. You're like, then you find yourself, you're like, no, I said pseudotumor. And that means it's kind of like, absolutely not. So we changed the name. Idiopathic intracranial hypertension. We diagnose that from that opening pressure with a lumbar puncture. So the pressure is high, And that pressure can put pressure on all the other nerves. So you typically see that with vision and on the optic chiasm. So you can see things with one eye or the papilledema or vision loss that you see with that in the presence of normal imaging. This is one that your pants loves. So one of the classic findings of this, so idiopathic, but the most common way, and the most common way I've seen it present in real life, is medication induced. So think back, teenagers, what do they have a lot on their skin? Acne. And if it had scarring or nodules, what do you send them for? Accutane. And what is Accutane an analog of? Vitamin A. So now you have a teenage girl who starts Accutane for acne. Maybe she's a little bit overweight, and she now comes in with these vision changes and headaches. What is your next step in management? It's LP, looking for idiopathic intracranial hypertension. So if you see buzzwords that have an overweight teenager who just started acne treatment, the other one would be a teenage female who starts oral contraceptives, that's another one. That's when you need to think, I know this one, idiopathic intracranial hypertension. So what do I need them to do? Stop the triggering medication. If it's medication induced, stop it. Weight loss can help. And then neurology would be your next line. So a lot of these ones, we had kids that would come in with idiopathic intracranial hypertension that would have recurrent LPs to just take off some of that pressure. So we could do that as well, and then diuretics to again take off some of that extra fluid. I got here. Okay, so practice question. Which of the following is your initial treatment steps in adolescents who present to the ED in status epilepticus? B, stabilize your airway. Okay, let's pretend B wasn't on there. What is the next thing that you would choose? Are you going to get a stat EEG?
No.
For the love of God, don't pick out. No. Are you going to do diazepam or an ABG or glucose?
Diazepam.
This would be a terrible question. I would never ask you this, but it would be ABG because I want to know my electrolytes first to know if that's the underlying cause.
Can you get
an ABG, then I would do diazepam. Glucose would be last, unless something was off with your ABG. So, terrible question, but just ways to make you think. Yes?
Having a seizure?
That's a great question. It is very hard. A lot of times you do
right?
Yeah.
Yeah.
A couple of these things for traumatic brain injuries, this kind of the end here is a little bit of potpourri on some different things. So when we are talking about these TBIs, most of the time you're talking about teenagers. Sometimes you are talking about motor vehicle accidents and things that happen in younger kids. Most of the time we're talking about concussions with this. So that's a big one. Could also have the bruise of the brain, contusion, and then the different types of hemorrhages. So leave that more for your ED lecture with epidural, subdural, and subarachnoid. You guys already nailed that one. Worst headache of your life one, and then also skull fractures. So the big one we're going to talk about is concussions. When I'm thinking about concussions, I truly do use the term traumatic brain injury with parents. I just saw a concussion follow-up last week in clinic, where one question is, how fast can you get back on the field? That's always their first question. It makes sense. Most kids are going to be okay from this. Most kids are going to have some headaches. They might have some cognitive reaction times. So that might mean I can't pay attention in class. It's basically everything that you're feeling now is post-concussion. I've had just one giant concussion. I don't know. But the reaction times, confusion, I can't pay attention. I hear it, but it's not inputting, some amnesia with that. But I think what I see most in practice is the emotional side. You'll have a kid that was pretty quiet that is now having some outbursts, or vice versa. You'll have a kid that was pretty emotional or pretty stable, and now there's a bunch of crying or anger. So there's some emotional lability that happens with concussions. And then some sleep issues, and then consciousness can be affected. Two different types of amnesia. So let's think about the kid that gets hit on the football field. So if you had retrograde amnesia, you have no idea What happened to get you to that? I woke up and I don't remember the play that I got hit on. Versus anterograde, I remember the hit and I can't get any new memories. So, and nothing after the hit. I don't have anything there. The longer they don't remember, increase of severity. So if they come in and they tell you, yeah, I'm missing a couple seconds, versus I don't remember the end of the game. Very different risk stratification for that. Oh, that's lovely. There you have it. Different risks. So thinking for who's more at risk, if you're playing on an artificial turf, why artificial turf? Yes, it's less forgiving, so it's more stiff. Again, this is one that I don't love as much. So males had football or rugby, females soccer and basketball. I would argue that female rugby, have you watched female rugby?
Great.
Female rugby and that male soccer is also one where they have a lot of headers as well. So anything where there's contact and the head is involved. Athletes, children with BMIs over 27, the idea is that they have grown rather rapidly and don't have necessarily the body mechanics. And then under 3 hours a week of training, do they really understand the mechanics of the sport and how to keep themselves safe? So you see increased risk with that. The time period that we're really worried about as providers is in that first 10 days after concussion. Are they going to get second concussions? Recurrent concussion, certainly the longer somebody does a sport, the longer they're at risk for having a concussion. And then just the quarterback position, because they're taking all the different sacks. When does March Madness start?
This week?
About that. This week? I don't know anything about sports, but I just remember that it's March. Sorry, that's a squirrel moment. Seizures. We said uncontrolled electrical activity. That can matter if your brain is being shaken up, and you as the provider are trying to risk stratify this. So at the time that your brain is getting rocked and you have a seizure, great prognosis. Because that makes sense. Your brain is getting rocked, so there's going to be some of that uncontrolled electrical activity. I expect that potentially. So at the time of injury, great prognosis. Right after the injury, the first few days, there's that localized edema, localized swelling that's going to change how the electrical patterns work in the brain. Still likely that you can see some uncontrolled electrical activity. When that edema goes away, we stop seizing. Still a pretty good prognosis. After a week, that's when you see the prognosis be very, very poor. At that point, it is no longer the local edema. They have started to scar, and those scars do not conduct electricity well, and then you see a much, much worse outcome. So worse outcome seizures are after that period after the concussion. Typically, you see this very, very short. They have symptoms not that long for most kids. Most kids are going to get well after a week or so, 7 to 10 days. You see this, the prolonged recovery, and this is one of those things, most times kids get better really fast, but children can often take a longer time to recover from this compared to adults. So things that I'm going to get a CT scan for: focal signs, rule out a bleed. That's the only time I'm getting a head CT. Otherwise, I'm not getting anything that I'm watching. So the other things for CT scan. When I say significant loss of consciousness, how long? Usually I would say more than 60 seconds. That's kind of my time frame. If you're out longer than a minute, what happened? There's a missing minute, right? I want to know what's going on. Post-traumatic amnesia, if it's prolonged, they still cannot remember, it's not starting to come back. A little bit more abnormal and considering a scan for that. And then persistent focal. If you see a skull fracture on your exam with your provider eyes, please get a CT scan in that case. And then if they're starting to deteriorate, what kind of bleed are you thinking at that point? They were fine, now they're not fine.
Epidural.
Correct, epidural. Yep. What I'm trying to prevent is your second impact syndrome. So in that short time frame, while they still have edema, are they getting hit again? And that's what we are trying to prevent. That is what second impact syndrome. At that point, if they already have that edema in the brain, that is going to cause a rapid increase in ICP and have much worse outcomes. We say 3 deaths every couple of years, and that's really what we're trying to prevent. If pediatricians and providers can prevent child deaths, that's what we jump up and down for and try to prevent, because that is what we don't want. Certainly we won't be able to prevent that for every single MVA that happens where they get a second concussion, but if they've had a concussion, we can certainly stop those ones. So how are we stopping that? We're stopping that with the return to play guidelines. So you will be, as the provider, the one that said, nope, stop, you don't get to play. I'm not clearing you for this until you are good to go. What does it mean to be good to go? So you'll need to know these ones. Each step can't be any faster than 24 hours. You need to go through a whole circadian rhythm, meaning a whole sleep cycle, and then a whole performance during the day with no symptoms to pass to the next step. You can't do it in 12 hours. You can't do it any faster than 24 hours. What you can do is if you have no symptoms in that whole 24-hour period, you get to graduate to the next one. So day 1, complete brain rests. Then you start adding light exercise back, meaning they can go walking, they could do a little bit of resistance training. Then you start adding your sports-specific things back, so sports-specific drills, no contact that you're doing. Day 4, they're progressing. Day 5 is a full contact practice. They're back potentially at day 6. So day 0 doesn't count. So this is functionally 7-day period, right? Thank God, because the NFL, we couldn't get people back in those 6 days. What would we do? But 24 hours is your time period to return to play. Other things that happen with post-concussive syndromes, if they're not responding and you get outside of that 7 to 10 day mark, you're up in the 2 weeks, things that we see this in, risk factors, the younger the kids. So if your brain gets rocked when you're younger, the likelihood of having some more significant risk factors and outcome is higher. The worst symptoms you had at the beginning, again, going to be that same thing. So what do you start seeing? So you can see everything from persistent headaches and those persistent symptoms, all the way up to I'm dizzy, I can't sleep, and I'm hallucinating. So those younger kids can have specifically some of these more exaggerated symptoms. These can last for a long time. This can affect school and significant school outcomes. And if this is really starting to last and you're young, that's when I get neurology on board to help with some post-concussive things. One final thing, there's a return to play guidelines, but schools are already also going to this, so you're going to start seeing more return to learn guidelines too, where you're saying, how much class can they go to? Can they do a full day? Can they test? Can they do homework? Can they do all of those things? So you're going to start seeing that you're signing return to play and return to learn as well. So please nobody go out and get a concussion so that I have to sign return to learn for ICAP. You have like, I don't know how many tests, 5 tests left. So let's just get these done, put you guys on phase 2. Continuing on the potpourri. So a little bit of sleep. This probably could be in block 1, but here it is. We're going to do it in block 3. A little bit of reminders of some of the things that happen with sleep. So if you, I don't know, did you guys talk a lot about sleep in neurology at all? Not much? Okay. Well, then you have 2 types of sleep. You have your REM, the rapid eye movements, and your non-REM. So your non-REM are the different stages, getting progressively deeper, 1, 2, 3. Let light sleep down into your deep sleep. This is what a lot of times, if you're taking sleeping medications, they'll put you into one of these stages that will keep you from either deep sleep or preventing REM sleep. So you're asleep, but you're not really getting that restorative rest. That's for a different day. The average time that infants stay asleep. Most of the average is 16 to 18, but we'll talk about on the next slide, much amount of variation that we see. Your toddlers starting to consolidate with a couple of naps, your school-age children consolidating even more, and then your adolescents at that 9 to 10 hours a day. Notice what age group says we need less than 8 hours a day. None of them. Do you see greater than over 12? Do you see adults only need 6 hours of sleep? No, right? We all humans need more than that. So it's a plug. When you get to phase 2, or even now, focus on your sleep. There will always be work. There will always be things to study. need you to sleep. I know you hate charts. I'm going to try to, let's pull it down a little bit for really what you're going to need. So this is those newborns, those neonates, in that first couple of weeks of life. So this is when parents will come in, and the biggest thing you have to deal with is what are the parents' expectations with sleep. They were told, sleep when your baby sleeps. Your baby's going to sleep all the time. You have some babies that will sleep 10 hours a day. That's normal. And you're like, I was promised way more sleep than this. Okay? There's other ones where they're asleep 19 hours, and they're like, are they okay? That's also normal. Okay? So most of them are 16 to 18, but that range is 10 to 19 hours. Most bottle-fed babies stay asleep a little bit longer. It takes a little bit longer to digest than your breastfed babies, so they might get a little bit more sleep than that. And then they're not awake more than about 1 to 2 hours at a time. Biggest thing from block 1, remind me, what position are they sleeping in? On their back? Do we have lots of bumpers and stuffies and all kinds of things? Nope, we don't do that. And then do we co-sleep?
No.
Nope. So we want different surfaces. So shared sleeping area, different surfaces. And then again, most of it is with the parent's expectation versus what the child is actually doing. For your little bit older kids, so now 2 months all the way up to about a year, ton of variability. So this is the most variable sleep stage. This is also when they will start to self-soothe. So they really don't do that until they're done with that kind of 4th trimester, which again is not a thing, a definition, trimester is 30 days. So that first 12 weeks of life, a lot of things happen. Remember, they don't make tears till 12 weeks. They do have colic in those first 12 weeks. They don't self-soothe for the first 12 weeks. They can't neurologically self-soothe. So if you have people that are parents that are like, we're going to start sleep training at 3 weeks. We're going to let them cry it out at 4 weeks. Like, neurologically, they don't have the pathways to be able to do that till about 12 weeks. We say, what's the earliest we can sleep train? Most kids is about 12 weeks. This is also when you see the self-soothing. As they're learning this, they will do a lot of rhythmic movements. So you'll see your parents, they'll say they're hitting their head on their crib, or they're doing some sort of weird movement where they're hitting themselves or something. Those are these rhythmic self-soothing movements that children are doing that are normal for this age. So a lot of parental reassurance about that. For your toddler ages, this is when they're starting to nap. And this is when you start to see a couple of insomnias and parasomnias that we'll talk about here in a minute. This is when your nighttime fears start to present, and this is when routine is the most critical. So routine is going to be something that you will see over and over. The reason I say that is because your toddler years, your 3 to 5 year olds, most of the time, most naps have gone away. There's still a quarter of them, about 15% that will still nap going into kindergarten. But if you are co-sleeping between 3 and 5, that has the highest correlation with having lifelong sleep issues. So public service announcement to your patients or to family, friends, anybody, that would be the time to avoid co-sleeping is ages 3 to 5. This is when your sleep problems become chronic, and if they are becoming chronic at that age, potentially lifelong. Your middle school kids, that's when you start to see behavioral patterns. So now you have things with media, electronics, they start to faint, school friends, they're nervous for things. So you start seeing obstructive sleep apnea increasing at this age, insufficient sleep, again, nobody should be under that 9 to 10 hours. And then once you start hitting puberty and adolescence, truly your circadian rhythm shifts. You want to be up later, you want to get up later. So you had this child who was bounding out of bed, ready to see the sun, it's like a Cinderella. Now as a teenager, you're like, are they dead? And like, they would just sleep all day if you let them. Very, very normal pattern for the teenagers. Truly their circadian rhythm shifts. So a couple of things when we see these behavioral insomnia, so sleep onset. So I know that literally everyone in this moment wants to be falling asleep right now. I get that, right? So if you fell asleep at this moment, you woke up in the parking lot, that would probably freak you out. Right? You'd be like, I don't know what has just happened. Have I had a concussion? I don't know if I should fall asleep in class anymore because I'm gonna wake up somewhere I don't know. That's functionally what this is. So if you fall asleep on mom or dad, or someone's holding you, and you wake up in a crib or in a bed, that's very concerning to the child. So this, when you see these sleep onset associations, that is what that means. So the recommendation is to put the child to sleep drowsy but awake, so that they fall asleep in the same place that they wake up in. The limit setting subtype is really when you start seeing children, so if you've ever been around children, they become like little Socrates at night, right? So there's two things that they do. They're like, I need a tissue, I need a glass of water, I have to use the bathroom, I need a stuffy, I need a blanket. Like, you're just like, how? But then they also are like, what's the meaning of life? I love you. You're just like, what? What is happening? And that is the limit setting subtype, where they will consistently see what kind of boundaries to push so that they do not have to go to bed. This is when nighttime fears come out as well. So there are two different sleep subtypes there in insomnias. The parasomnias are when you are in a true sleep pattern, in REM or non-REM sleep, and your body is doing something because of your developmental maturation levels. So this is another one of those that has a strong genetic predisposition. We're going to talk about these 4 different types. So sleepwalking, big concern for safety in this. So what the child's body is supposed to get told is, you're sleeping now, be paralyzed, don't start walking around, right? So that you're not getting up. If those signals are mismatched, which typically happens in a developing child where all the signals are still learning to connect, the child asleep, if you were on an EEG, asleep is getting up and walking around and doing all kinds of sleepwalking things. So big thing for that, lock the doors, make sure they can't turn on the stove, make sure they don't have access to water, things like that. Then the difference between night terrors and nightmares. This is always a big one. Parents love this question. They love it. So what they'll always try to do is, can you distinguish between nightmares and night terrors? So the night terror happens early in the night. Parents often are still awake. So if you go to put a kid to bed at 7, 8 o'clock at night, parents still up. So very, very early in the sleep cycle. The child typically wakes up with a blood-curdling scream or something that makes you totally freaked out. So parents describe like this is this horrendous moment. You're trying to wake the kid up, the kid just kind of doesn't really wake up, but in the morning they have no idea what happened. Don't remember anything whatsoever, right? So parents are like, you don't remember when you sounded like you were getting murdered? You're like, nope, no memory of that. As opposed to nightmares, where that's the last part of the night, so very, very early in the morning, usually 4, 5, 6 a.m., when they're in REM, and they wake up and they are totally freaked out and they can remember exactly what it was. So very, very different ways that you're doing that. Confusional arousal is somewhere in the middle. I've never seen that tested for any kind of board testing, but it's really somewhere in between a sleep terror and a nightmare. What is your treatment then? First of all, just demystifying that this will go away. Well, hopefully you guys aren't still having night terrors. Maybe you have nightmares about this place. I don't know. But safety precautions, we already talked about those. And then scheduled wakenings. So if you have recurrent night terrors, you need to interrupt that sleep cycle. You can use it for nightmares as well, but typically you see it for night terrors. So if you put the kid out of bed 7, 8 o'clock at night, having the parents wake them up very briefly before they go to bed. So if they're going to bed 10, 11 o'clock at night, rouse them just enough, or hey, let's go use the restroom, come back to bed. Something that interrupts that sleep cycle so they don't have that night terror. That can be helpful. And then avoiding shows or movies that are very scary. You never know what this is going to be for kids. Did anyone here, you ever watch the movie The Sandlot? Or am I like dating myself? So The Sandlot, okay? So when I was little, me and my sister watched The Sandlot, and she was so freaked out when they're telling those like stories in the little treehouse, and he's like, forever, forever. Like, so still to this day, we're like in our 40s, and I can just be like, forever. She's like, stop it. Like, it's just freaked her out, right? So you don't know what's going to cause this for kids, but you can sometimes see that shows, movies, things they see, things they hear can cause them nightmares. If you're really thinking, I need to medicate this kid, that's where neurology should probably be on board as well. So that's going to be really outside of scope of primary care. By adolescence, we said they're already this exaggerated and delayed type schedule. So their circadian rhythm, the way I will sometimes explain it to parents, is they're on a 25-hour circadian rhythm. They want to stay awake longer and they want to wake up later. So some of the problems with that is that school starts not later, and they are ending up really compromising the amount of sleep that they get. They end up trying to make up for that on the weekends, and sometimes that will just worsen the problem and cause some of the things that we see that exaggerated in adolescence, some anxiety, depression, emotional regulation disorders. For the parents and the child, talking about this and demystifying it, that it will likely go away as they get older. Something that is objective that they can kind of set towards this, and some reinforcement. Sleep hygiene, is that a big one? So if you see that on the test question, it's always sleep hygiene, like get rid of screens out of the bedroom, making sure they have a cool environment, that it is dark, all of those type things. The one caveat with your meds here is things that I would consider for sleep initiation. So I'm trying to establish a pattern, helping with melatonin and clonidine. This would not be something that if someone's on like, hey, I'm on melatonin, I've been on melatonin for 7 years, you're like, oh. Maybe not the best use of that. Good for traveling, good for things where they're off time, good for sleep initiation. If you're starting a routine, starting a pattern, it's not as much for a long term. We got a couple more minutes. So, malformations of the CNS. These are a couple that I don't think we really talk about elsewhere a whole lot, but they are part of your PANCE blueprint, so we are going to talk about them. So an Arnold-Chiari malformation. So we already said that a lot of stuff happens in that posterior fossa part of the brain for these kids, and one of those things can be if the cerebellar tonsils are protruding down into the foramen magnum. That should not be the case, but in the Arnold-Chiari malformation, that's what's going on. There's two different types. We have to distinguish them through imaging. But in type 1, the cerebellar tonsils are protruding through that foramen magnum, and that pressure that it's putting on there can cause headaches, can cause neck pain, can cause some of these neurologic symptoms that we're seeing. It's typically mostly with that because of that pressure, and so it's headaches. Not as much spasticity or any kind of seizure-like disorder. You see that more in type 2, where there's truly a abnormal fourth ventricle, so it's elongated, and the cerebellar tonsils kind of protrude into that fourth ventricle. That one has more symptoms, and they're more neurologic symptoms that you see with that type of Arnold-Chiari malformation. So on the far left-hand side is going to be normal. See, there's plenty of room for the cerebellum in that posterior fossa. That type 1, that cerebellar tonsils are slipping into that foramen magnum, putting pressure there, versus your type 2, where that elongated fourth ventricle is allowing the tonsils to displace into that. You've gotten imaging. What kind of imaging do you need for this? It's got the posterior fossa involved.
MRI.
MRI. And who are you consulting for this?
Neuro.
What is neuro going to do? Who do you need to consult?
Neurosurgery.
Neurosurgery. So this is going to be a neurosurgical intervention for this. Because neurology is going to be like, yeah, it looks like those tonsils are protruding. So this becomes a surgical management to enlarge the foramen magnum, or potentially have some sort of shunt that they will do for these children to shunt extra fluid away to get that pressure off. The other one that I think is fascinating that your PANCE wants you to know this one, but is the Danny Walker formation. So this is another posterior fossa issue. So you get some agenesis of the cerebellar vermis, and so you end up with, again, a very dilated and cystic fourth ventricle. So that posterior fossa becomes significantly enlarged. So you see a really large head circumference for kids. So if you're under that 6 months of age, you can go ultrasound that area. What was that area called right up top? That soft spot, what's that called? That anterior fontanelle, good. So you can ultrasound that head. You can sometimes see that their milestones are delayed. This is going to be another one that neurosurgery is going to be involved in, to say you got to get some of that extra fluid off of there. So that enlarged posterior fossa, because of this cystic dilation and this disconnection and agencies of the vermis. We never figured out why they're very concerned about this one, but a few other things as we continue our potpourri of peds neuro. We probably actually won't finish this one today. We'll pick it up tomorrow. So you've done Guillain-Barré syndrome in probably several of the classes. So where does it start when you start having symptoms? Everyone's pointing down. It starts in your lower extremities and works its way up. So it's an ascending flaccid paralysis. So that would be your biggest defining thing. So far, everything we've talked about today has hypertonia. There is that rigidity associated with it. There is some sort of spasticity. That's the exact opposite here. Here has the flaccid paralysis. So ascending and symmetric flaccid paralysis. We're hospitalizing these kiddos. Why? Diaphragm. I don't want it to ascend so high that it now hits their diaphragm and they're having respiratory issues. So that is certainly the thing that I don't want. I typically associate this with the mycoplasma pneumoniae. So I think atypical pneumonia causing an atypical response. I put these two together for kids. You can see it happen with other things, but typically that mycoplasma. It resolves the same way it started, so it comes all the way up and it then starts to rescend. And so a lot of times we're doing this for airway. We're also giving IVIG. So if you think about this, IVIG is really weird. So if they're thinking, I'm going to take a little bit of my plasma and your plasma and your plasma and your plasma and combine all of our IGs and hope that it helps, that's a weird treatment, but it does seem to work. And there's collective antibodies against some sort of virus or bacteria that is causing this for the most part. IVIG can also cause anaphylaxis for that reason, because you're also putting in all kinds of stuff from other people as well. So things to be aware of. Other things that can cause that flaccid paralysis would be botulism, so this Clostridium botulinum, so it's a neurotoxin that is happening. So this is complete relaxation. What's the exact opposite of that? If you have a neurotoxin causing contraction. Tetanus. Clostridium tetani. So the exact opposite of that would be this. Imagine if we use like tetanus toxin instead of Botox toxin, and everyone just like anyway. What you see in kids though, this is why we avoid honey, because it has potential for these toxins that are not handled well in the infantile gut. So if that gut isn't moving because it's paralyzed, that flaccid paralysis, you're not going to be able to move things through. So you're not going to suck well. You're going to have some constipation that follows that. Anything along that process isn't functioning very well at all. So if you can't gag on something, you're more likely to aspirate it. So aspiration becomes a risk for this. Again, admitting to the hospital, IVIG until this toxin passes through. Your muscular dystrophies are another type that we see for some of this, not flaccid paralysis, but when you see degenerative diseases. So these are genetic, and this is when you have your myofibers, your myocytes, that are typically put together with, if you think of the 2x4s of the myocytes, it's with the gene and with the protein dystrophin. So if you're putting together your 2x4s of dystrophin of your myocytes, that's what's happening, is that's where the genetic defect is. So your body can't make any more of these 2x4s, or the muscle cells. The common types you see are Duchenne's muscular dystrophy, and Becker's is a mild form of that. The boards love Duchenne's muscular dystrophy. For whatever reason, they love this one. So what's happening with this? Well, it's X-linked. So if you give a situation where there's a little girl, don't pick this one. It's not going to be that one. You see this in little boys. You see that they're fine as babies, because at first the gene makes enough of the 2x4s, and they're not using a lot of these muscles. They're just laying there like little cockroaches, right? So now you see this delay in milestones, and the first thing you see is these little boys, as they're learning to walk, become obligatory toe walkers. And they're toe walking because they don't have the musculature architecture in their calves to be able to hold them up. So that's the first thing you'll start seeing. Then you start seeing it as they're toddlers, they're not hitting some of their milestones. So what's happening? So we already said they're toe walking. Then they don't have enough of the muscle in their hip girdles to be able to walk forward. So they end up with this wide gait side to side. So they end up toe walking kind of side to side to propel themselves forward. The other thing you'll see with this pseudo hypertrophy of the calves, let's continue our 2x4 analogy here. Say you built a house, you had rotting 2x4s, and instead of replacing them with new 2x4s, someone came in and said, let's just use spray foam. You're like, okay, right? That's what's happening. The body doesn't have dystrophin to make the cytoproteins and the structure of the cytoskeleton. It fills it in with fibrotic tissue. So that's expanded and larger tissue. So the calves, they're not just big giant calves, it's fibrotic tissue. So it's pseudo hypertrophy. Their circumference is larger, but there's no more muscle. That's what's going on. Then the thing that you will always see, that I've seen in every single board question and in real life, is the Gower sign or the Gower maneuver. So if you've ever watched a 70-year-olds, 80-year-olds get up off the floor, they are using their entire body to crawl up themselves. That's what's happening with a 3-year-old. That's not normal. If you watch a 3-year-old get up normally, they're like the Incredibles, and they're like, just, they go. Right? And you're like, well, that was weird. I don't even know how you did that. So if you have a 3-year-old with a wide gait who's trying to walk up themselves through the Gower sign, can be nothing else besides muscular dystrophy for this. This will continue to ascend. They will eventually lose arm weakness, upper extremity weakness, and the diaphragm, be wheelchair bound by the time they're teenagers. Very, very sad outcomes. What would be your workup then? First, I want to see their electrolytes, make sure nothing's going on. These toddlers, CMP, CBC. Your muscle enzymes, so is CK going to be through the roof. So it's going to be the thing that you're going to look at. Eventually, neurology will do an LP and they will do a muscle biopsy where the genetic studies will confirm. So that's what your ultimate diagnostic testing is going to be for that. Before we get started in neurocutaneous disorders, this is probably a good time to call it. We will pick up here tomorrow. Questions, comments, concerns, anxieties, frustrations, any other great ideas in the last 2 hours without graduation?